Welcome back to another episode of Rehab Now with consultant physiatrist Dr. Paula Dawson, our rehabilitation medical doctor.
Hello.
Rehab Now is brought to you by the Rehabilitation Institute of the Caribbean, Winchester MRI, Immune Active Deck, and Almighty Studios. I'm your host today, Alicia Taylor. This week we are back with a back. Yeah, man.
We're back again with the back.
We're back again with the back
because the back.
Yeah, it was just so much, and so we had to continue. But make sure to check out our social media pages. We have Rehab Institute Caribbean, Dr. Paula Dawson, and Alicia Taylor Music for Facebook. It's Rehabilitation Institute of the Caribbean, and our website rehabcaribbean.com.
Yes.
Now, Doc.
Yes.
Let's get back.
To the back.
To the back.
Yes. Hi, listeners. I am glad to be back.
All right.
It is glad to be back, too.
It is. The back is glad to be back. We are glad to be back.
Right. So I am glad to be back here with you to expound on the back, to tell more about back.
Yeah, man.
And so, you see, the reason we are doing 2 episodes on the back and back pain is because back pain is so universal.
Yeah.
You know, everyone at some point in their lives, as I said before in the last episode, that will have back pain, you know, whether they are young, middle-aged, or old, depending on what they're doing. Even children have back
I was just
pain.
going to ask, even children have back pain.
My son has back pain, especially now when they were doing Zoom at home. I'm sure parents would have experienced this. And we're going to do an episode on children. Well, fortunately, we're praying that the pandemic is, coming to a close. Although you must still exercise you must still, wash your hands, sanitize your hands. Right. You still want to be safe because, we're not out of the woods until it's completely eradicated. Right. But when, children were at home doing school from home, kids were having back pain. They were sedentary. Kids were put on weight. A lot of children actually put on a little bit of weight because they weren't as active. True. And so children can have back pain as well. So back pain is everywhere. It's almost guaranteed in everyone at some point in their lives.
Wow, that's unfortunate.
It is. But the wonderful thing about back pain is it can be treated.
You've been saying that, You've been saying that.
I love the fact that back pain can be treated. So the last time we spoke about some things, but let us talk about what do people complain of.
Okay.
When you had your back pain, what did you feel?
This might take a little while, excuse me. So at one point there was a burning.
Where?
In our back, like the lower back.
Right.
So there was a burning, and then at one point it felt like a sharp.
Oh, I love the way how you describe that, because that's some of the things we ask the patient. The character of the pain. Is it burning, aching, cramping, numbing, tingling?
I'm a good patient.
You are a very good patient.
Man.
Good historian, we call you, because you're able to give us the history.
Oh, I like that.
Adequately. So we first want to know where is the pain? Is it in the middle? Is it to the right? Is it to the left?
Lumbar, the
lumbar area, right. The next thing we ask, is it localized? Does the pain stay in the back?
Okay.
Localized pain. So we call that axial, A-X-I-A-L, axial back pain. And that kind of clues us into some things.
Right.
When you talk about
You mean
axial.
so if it's in the back, or if it's in the back and then in your arm?
Well, technically,
is that what you mean?
No.
Okay.
Well, I'm glad you're going down that route because it's where I'm going now.
Okay.
So if it's in the back and it usually radiates down the leg. Right. So arm pain will radiate from the cervical spine. Oh. So these are the nerves where you get innervation or nerve sensation to the upper limb from the cervical spine.
Okay.
But the lumbar spine, the lower back, will send innervation nerves
in your leg
to the legs, right? And so we ask, where's the back pain? Is it localized to the back? Right, left? Does it move? Does it radiate? Does it go into the buttocks? Does it go to the front of the leg, the back of the leg? And so when I'm asking my patient, where's your pain? Front of the leg, back of the leg, big toe, little toe, foot bottom, top of the foot. It kind of clues me in to what or where in the spine. Because from the history, I can say, okay, you have an herniated disc at L5, S1 or L4-5 based on the history. So I can actually localize, which is why I ask all these questions and I do a detailed examination.
Right.
And so L5, S1 or L4 or L5 or L3. And so this will kind of key us into the type, the location, 1. You want to know the character, 2. You want to know the aggravating factors. So I'll ask the patient, what makes the pain worse? Is it sitting? Is it standing? Is it
that's
bending
good
forward?
stuff.
Is it bending backward? And then what relieving factors? Because that will also help me to make a diagnosis. So when you're going to the doctor, you want to know, one, how long? When did the back pain start? So go with these. So was it 10 years, 1 day, 2 day? Is it a 10-year? And now you have a flare-up. So you have acute on chronic. So you have a new flare on a long-standing problem.
What a terrible thing. What a terrible situation.
But the good thing is this terrible situation can be fixed. Yeah, so you can have acute on chronic. So we usually ask how long, where, in the lower back, what's the character, is it localized, does it radiate down? Because if it's radiating, we know that some nerve is referred pain. It's touching the nerve, or the nerve is playing a part in producing the type of pain that you have.
Interesting.
Is it worse with movement? It can be mechanical. Is it better with standing up? Some people say it's better with stretching. So it depends on the pain. And that's how the back is such an amazing thing. So we ask about that. The next thing we ask is, what was a precipitating factor? What were you doing?
Thank you for that one.
Precipitation. What causes it to come on in the first place? And what I always ask patients, if you were to rate the back pain out of 10, 0 being no pain, 10 is the worst pain ever imaginable. 5 is like you can't do housework, 6 you can't concentrate. That's how you rate pain in general. It's called visual analog scale or numeric rating scale, NRS. 0 to 10, 10 is the worst. And in this case, 10 is not the best. You say get 10 out of 10. No, 10 out of 10 pain is
10
bad.
terrible, man. 10 terrible in this case.
10 is terrible, right? And so, you want to ask the patients all of these questions so that you are able to get a good idea of the pain. You also want to know if the patient has had surgery or if there are any other underlying conditions. Like, for example, if they were diagnosed, if it's a male, if he has had prostate cancer, you want to make sure, because, some tumors, metastatic tumors can go to the spine.
Oh, yes.
So you want to get good history. You want to know if the patient has endometriosis, because you can misdiagnose endometriosis or some intra-abdominal thing for back pain. Oh, wow. And so those things now, their treatment is with a different type of doctor. So you want to go to the gynecologist for endometriosis.
Okay.
Right, and if it's bowel, which is like the colon and that kind of stuff, you want to go to like a general surgeon. It can be urology. It could be bladder. So you might have to go to your urologist, right? And so that's the wonderful thing about medicine. There are so many specialization, and in Jamaica, we're getting there, and we have so many, fully qualified people with the different specialty areas. Back in the day, is one doctor used to do everything,
Yeah, man.
Doctor
General
Dr.
practitioner.
Yeah, the surgery for appendix, everything. Everything. And now we're growing, and I just, that's the beauty of the University of the West Indies.
Oh, stop big them up. Big up
to
my
you training school. Yes, man. And so these are some of the things that the patient will complain of. I know some patients will say, Doc, what can I do? I went through the last time the treatment protocol where you want to start with the algorithm. You remember the algorithm?
I do. Rehab? Is that one?
Rehab
so
has
rehab
3 areas.
Medication. Wait, another summary.
No, you're still in rehab. Rehab has
3 parts.
Physical therapy first.
Not gonna remember the journey.
Home exercise and lifestyle.
Great.
We have to look at those.
Never write that down, so I never remember that one.
All right, so let's talk about physical therapy. What is physical therapy? Now, physical therapy is done by a physical therapist. And at the Rehabilitation Institute of the Caribbean, we have a fantastic team of therapists, right? And so not every exercise will work for back pain. You have some patients where they'll do an exercise called Mackenzie where you extend and it makes the pain better. You have another set of patients, you do the exact same thing,
and
extend,
makes it worse.
So every patient is different. And so research has shown that exercise is good, but spine-specific exercise is better. So someone said, but I run every day for the past 25 years, and why do I have back pain? Because it's good to exercise. Cardiovascular is good. It maintains your cardiovascular system. Your heart is, staying strong.
Healthy, yeah.
And healthy, correct. However, it may not be specific for your spine. A lot of times, some of our international athletes that I treat, they have severe back pain. But they're strong because the deep muscles, you have different exercise, spine-specific exercise, which is why you need a physical therapist and a spine specialist to ensure that you're doing the right thing.
What is the difference between a physical therapist and a massage therapist?
All right. So both are on the rehab team.
Okay.
And so a physical therapist will go to physical therapy school. We have a wonderful school at the
We do?
University of West Indies. Yeah, we have a physical therapy school. And we produce some great physical therapists. And so they do physical therapy. So let me do the easy one. Massage therapy. GC Foster, another fantastic school. I believe UTech has a massage therapy program. I'm not sure, but I know for sure GC Foster has a program. And a massage therapist will do mostly massage. Please forgive me if I forget anything else, but they're not trained to do physical therapy. Right? Massage therapy is an important part of the rehab team.
Yeah.
All right. And so physical therapy will go in their program, they'll go through a lot. Maybe, we have a program on what is a physical therapist.
We do.
We're going to have one of our very own doctor, either he's a doctor of physical therapy, Anthony Miller, or I think it might be Tashara Harriet.
Wow. Nice. Nice.
It's a nice name.
No, yeah, you're right.
Big up Anthony Millers out there. Right. And so we're going to do a show on physical therapy. And so they will expand more on what physical therapy is.
Okay.
Right? And so just to finish off rehab before we go off to a break, because I know you're going to tell me to go to our break.
How you know so good, man? Yeah, man.
Go
ahead.
Lifestyle. Lifestyle is important. And home exercise, spine-specific exercise. So when we have a patient that comes in for therapy, we usually give you homework. If you don't do homework, you're not get better.
I agree.
You understand? You have to do the homework.
100%.
So
to my students all the time. I'm sorry, go ahead.
Yes. What do you teach?
Voice.
Sing for me.
Talk. I'm gonna sing, man. You know what? We're gonna go to the break. I'm sure there's some singing in the break. We'll be right back. Stay with us, please.
Yes.
Welcome back to Rehab Now. If you're just joining us, we're talking about back pain. We're back with the back.
Yes, we are.
Doc, we did already have the episode with the physical therapist. So because you never there, you never there. Right.
Yes.
So that's why.
Yes.
Okay.
Understood.
Yeah, man.
Understood.
So back to the back.
Back to the back. And so, I was going through the algorithm of treatment, and a lot of patients will say, listen, should I wear a back brace?
Yes.
Should I get ultrasound? Should I get TENS, transcutaneous electrical nerve stimulator, which is a little machine that you can use? There are so many treatment modalities or mode of treatment for the back. And what we do at the Rehabilitation Institute of the Caribbean, every patient is different. Every patient is different. Some patients may need ultrasound. We have something called Shockwave Therapy, which is it's a machine that we got from Medical Link. Big up. Medical Link. And it's a shockwave where we use sound wave. It's called extracorporeal. Sound, right. So it's shockwave. It's sound wave. So it's extracorporeal, outside of the body, corpse, extracorporeal shockwave therapy, where we actually use sound waves to treat problems in the body. And for example, if you have a back pain that's been going on for a long time, and then you have these myofascial, which are the trigger points in the body, and you have these knots, and they're like old and scarred down. We use a shockwave, and the shockwave can actually bring in new blood vessels called neovascularization.
It brings in new blood vessels.
Yes, it causes blood vessels to go to the area, because when you have an injury for a very long time, you can have a lot of scar tissue. If you have scar tissue, you don't have good blood flow. If you don't have good blood flow, nutrients can't go there, and so you can't heal the area. And so for example, shockwave, we can use a shockwave will cause neovascularization, And this can actually help with healing again. This can actually help with healing again. And so we have laser at the Rehab Institute of the Caribbean. We have shortwave diathermy. This is another high-end type of modality.
Sorry, I was still stuck at laser.
Yes.
What happened with it? Is that like fire? Like laser? What do you mean laser?
Laser is it's a low intensity laser, which is kind of like a light. Right. It's kind of a light that we use, but it's a special machine that provides a particular wavelength of laser, so it doesn't burn, like laser from the movie goes.
Yeah, man, that's what I'm thinking about right now, just like to burn.
Like the saber thing
Star Trek
from Star Trek.
Wow.
And right, but no, that's not what we use. But it is a low intensity laser that we use, and that actually it's the same premise where it helps to make the area more acute, meaning it turns an old injury into a new injury, so you have better blood flow, so you get better healing in the area.
Sorry to cut you, Doc, but a lot of persons listening to this now and them just get a little bit scared. Oh gosh, I'm having these issues, and this is what will help, but I'm a bit afraid.
Yes.
And there's this little phrase that people talk about all the time called side effects.
Oh, I like that.
Yeah.
I like that. And that is true. So a lot of these modalities have been well researched. And of course, they must be done by someone who's trained to use it, which is why we recommend the physical therapists are the ones that use these machines. And of course, these machines, except, for example, the Shockwave, they have a timer. You can't go over a certain.
Okay.
And so it is patient responsive dependent, meaning we're using it and you tell us, can you manage it? Can't you manage it? All right, so we put you, and so the Shockwave, so we put them, it looks like a little gun, and we put it on your hair. So it's just really tapping. It's really just tapping. And it really feels good. I have had it done to me, and I had a little stiffness in my neck, and I couldn't turn my neck past a certain point. And I'm not making this up. And patients will tell you, some of our athletes will tell you, you are kind of stuck in a particular way because the muscles are locked. And you use a Shockwave, and at the end of the session, you can actually move a lot better. However, it will come back if you do nothing. So we've now loosened it up. You must do your part to do your home exercise program. And that's the important thing. And so, but, all these modalities are good. I mean, and there are more that we have. Interferential, and iontophoresis, all sorts of stuff. And iontophoresis is where we use electrical current, and we put like medication on the skin, anti-inflammatory, and we use the current to kind of push the medication down, for want of a better description.
Electrical current, man. Electrical current. And we're not going to have any side effects.
No. You know what? That kind of sounds a little weird. However, it's a nice little, almost like a little massage. You feel a little tingle. Like when you put on menthol on the skin and it kind of feel a little.
Okay, yeah.
That's how it feels. That's really how it feels.
Okay.
You don't get any shock.
Okay.
Right? You feel a nice.
You don't get electrocuted.
You don't get electrocuted.
Okay. Just want to make sure. I'm asking for the people.
Have you ever seen someone with an ECG cable on them, like them doing an ECG?
I have seen them.
So that's similar to that. We use that sticky pad. A little sticky pad like that, and it goes through that nice little sticky pad.
Still very scary. I just want you to know I've done an ECG, and man,
the only thing that hurts in an ECG is when you're taking off the pads.
Actually, it's true. No, you're right.
ECG right. Doesn't hurt at all.
Man,
I know.
Ouch.
I know. Right, and so I just want to say, with all those modalities, the most important thing, however, is how the physical therapist or the rehab specialist examines the patient. So it's patient specific. So not every modality will work on everybody.
Okay.
And so the physical therapist has to know what to do. And so I love the guys at Rehab Institute of the Caribbean because they're so skilled. We see a lot of patients with a lot of complications and combinations of diseases.
Combination of complications.
Yes. And they do so well. And they do so well. But the important thing is the tailored program that our physical therapists will make for these patients. And the most important thing...
unique.
And the patient has to play their part. It cannot be that the therapist is giving you all of this thing to do and you go home and you do nothing. A lot of times when I see patients for the first time and they've had things for a long time and it's kind of quiet, I said to them, you're going to hurt at first. Like when you're in high school and you go summer holidays and you come back and start the PE and your piano?
Yep.
I always tell patients, When you start your therapy, you're going to say, me things of them people didn't know what I'm going to do.
Oh,
But
that's
then
true.
you will feel better. You have to continue the program and you'll feel better. Now, we have a team. I love to talk about the team because, mark you, there's some things in therapy that will make you worse if it's not done properly. And you have to give us the feedback. In spine medicine, they have this thing they call mechanical diagnosis and treatment. We have to determine what is right for you.
Okay.
So not everything will work for everybody, but something will be specific that will work for you.
Something will work for you.
Right. And so, when that doesn't work, you go to the next algorithm, which is medication. So I want to talk a little bit about how medications work for back pain.
Okay.
All right. So I always start low. Acetaminophen, that is the generic name for Panadol, Tylenol, Cetamol, all of them. And so we want to start with that. There are some patients where that can actually work. And that's all they need. Pain control, it works. If that's all it is, then we go with that.
Okay, medication.
Medication.
Treat the problem.
Right.
Okay, fine.
If that doesn't work, they may need an anti-inflammatory called non-steroidal anti-inflammatory. NSAID, like the diclofenacs. Right. And, not to call any brands, we have the Voltaren, the Cataflam, the Ibuprofen, the Advil, the Aleve, that family, the Arcoxia, the Celecoxib, all of those, the Celebrex.
Because they're stronger.
They work different. So they're an anti-inflammatory.
Okay,
So I have patients that have been to many doctors and they've been on a lot of medications and they say the medications don't work. And I say the medication possibly worked, but sometimes you need to approach the pain from the 3 different type of pain processes.
Makes
One is the
sense.
inflammation, you need an anti-inflammatory.
Yeah.
One, you need pain control, which is the analgesic, which is like the acetaminophen or something called tramadol or codeine, Panadine with codeine. And then after that, then you have another medication that we use for nerve called neuropathic pain medication. So the neuropathic, so now when you have sciatica pain going down the leg or referred pain, you use neuropathic pain medication like the gabapentin or the pregabalin. These are the generic name. We also use amitriptyline, Cymbalta. These are antidepressants. In higher doses, we use a baby dose, half dose of them, and they help the nerve pain. And the thing with pain is once you've had pain for a long time, you want to get the pain under control. What do I mean by that? If I were to pinch you for 1 year, it creates a footprint in your brain and your spinal cord, a path. If I stop pinching you, you still feel it.
Wow, look at that.
Until you have to retrain the processes. And that's what the gabapentin and the pregabalin will do, yes. And so that is important.
So good. That is good stuff.
Yes.
I believe it.
Yeah, man. And then there is an aspect of pain management that we have to approach, which is the psychological part of it. The brain. Believe, kill, and believe, cure, Jamaican people always say.
Trust me.
So every patient that comes into my office, I believe that they have pain, but sometimes your emotions, you can get something. There's a scientific thing called convergence, where you've had pain for a long time, where the emotional fibers kind of piggyback on the nociceptors, which are the pain fibers, and they register as pain. The same thing can happen with temperature, where the temperature fibers converge with the nociceptors and you have pain. So people say, when the temperature changes, I have pain. There's a scientific explanation. Similarly, they say when they move, outside of having like arthritis in the joint, when you've had chronic pain, they say, any movement me do me have pain. It is also because of the convergence of the mechanoreceptors with the nociceptors. That sound, mechano means mechanical receptors. Nociceptors, noci is pain. So you can have convergence. And so you have the mechanical pain, the nociceptive pain, and you have the convergence together with that. And then we use the pain medication, the nerve medication that I talk about, like the gabapentin, the pregabalin, and the amitriptyline and all of those. And of course, the epidural steroid injection, which is what I do. On the X-ray guidance, we inject into, people don't like it when I say that, into the spine. Inject into the spine, but you don't push the needle in the spine. We use a special machine called a C-arm. You're not saying anything, Alicia.
Inject into the spine. I'm sorry, I'm still at inject into the spine. Continue.
Right. And so what do we use? People always said, oh, so what do you put into the spine? Okay, thank you for asking. We use lidocaine, which is, Jamaican people say when you go to the dentist and them cocaine in your teeth.
Right.
You ever hear that yet?
I've heard it.
All right. So it's not cocaine. It's really lidocaine or xylocaine. Those are anesthetic agents,
I
right?
understand why I'm thinking of cocaine.
Yeah, because it's the cane family.
It's the cane for me.
It's the cane family. It's not cane like sugar cane, it's
No, man,
C-A-I-N-E.
Got it.
C-A-I-N, right. And so we numb the skin, so we use lidocaine or bupivacaine, that's another cane that we use, or Marcaine, that's another cane. And so we numb the area so you get immediate relief if we're in the right spot. So the injection is diagnostic, and in addition to that, we use steroid, the good steroid. Not the steroid that they use to pump up. It's the steroid that we use, glucocorticoids, which is if you're bitten by a bee, stung by a bee. Bees can bite you. Stung by a bee, and then the bee make you start swell up. Then you get the steroid to quiet you down. Or if you have asthma, the asthma pump with the steroid.
I know that.
Right. And so that's good. And so that's how we approach back pain in terms of treatment. I just love treating back pains because patients do well.
You sound so excited about treating the
love
back
back
pain. You love the fact that you're able to treat back pain and to help persons.
As long as the patients do what they're supposed to do.
So you hear that, everyone? If you have back pain out there, don't worry. It's treatable. But you have to do your homework. You have to do your part, or else it's going to come back.
That is correct.
Yeah, it's going to come back. So thank you, Doc. Very insightful. I can't believe the things I learned. Wow. So that's it for Rehab now. Thank you for listening. Thank you to Power 106, our show producers, Renee, Stacy, Jeff is going to kill me. And our engineers. The next week we will be in the month of May. And we celebrate our children by discussing topics that affect them. Thank you again to our sponsors, Rehab, Rehabilitation Institute of the Caribbean, Winchester MRI, Immune Active Denk, and Almighty Studios. We will see you next week, same time. Blessings.
Bye. Blessings.